Okay, welcome to the SAGES webinar tonight. Just a few introductory slides initially from SAGES. So join SAGES now, and there's a good discount to the SAGES meetings if you're a member for cutting edge education, professional development, meeting, webinars, fellow courses actually, when the pandemic is over, and some online learning. Obviously, SAGES has a lot of members, about 8,000, big network, surgical endoscopic experts, media group. There's really a committee on everything, really. You get a subscription to a surgical endoscopy, and there are also research grants and career development awards. And there are lots of involvement and leadership opportunities in committee, task force, and peer reviews also for residents. And so the vision of SAGES, reimagining surgical care for a healthier world. The mission is to innovate, educate, and collaborate to improve patient care. And the values are inclusivity, innovation, service, excellence, global community, and then fun, obviously. SAGES membership, there are 3 categories. Residents would be candidate members as well as fellowships. Is pretty cheap for them, and active are the surgeons in Canada and the US, as well as medical students. And the SAGES meeting currently scheduled as in-person meeting at the end of August for 4 days in Las Vegas. So if you want to take a trip to Las Vegas, it's probably one of the first in-person meetings, and most likely it's going to happen. So those were introductory slides. Let me switch my slides now to the introduction of our theme tonight. Okay, so this tonight we have a webinar on surgical chest wall deformities, and this is a collaboration between the RAF committee, the Resident and Fellow Training Committee, as well as the Pediatric Committee. I'm the chair of the Pediatric Committee. My name is Stefan Scholz, I'm from Pittsburgh. And Michael Award is the chair of the RAF Committee. So what does SAGES have to do with chest wall deformities? It seems awkward, but it's a society of innovation, and excavatum or chest wall malformations is really a story of innovation and continues really. It's also mentioned in the SAGES wiki, you can Google it, and there's a chapter in the SAGES manual of pediatric minimal invasive surgery on it. And chest wall operations are really performed by a broad spectrum of surgeons, mostly pediatric surgeons, probably some thoracic surgeons, but also more and more acute care and trauma surgeons who operate on the chest. And the spectrum is broad. You see in the first picture on the in the middle, kind of, it's a regular Pectus Excavatum, almost symmetrical. And often you see this already in babies and infants, as the 2 pictures above. And the pictures on the bottom is really Pectus Carinatum, something coming out the chest, just coming asymmetrically or even symmetrically out, essentially. And there can be really bad forms of it, of the excavatum in the upper corner, or special forms like those on the bottom, which we call Pectus arcuatum or Carinatum syndrome. This is a very bony kind of malformation. So there's a whole spectrum with nuances. You can become an Olympic winner having a Pectus excavatum. The guy on the left is Cody Miller, Michael Phelps in the middle, and he has a pretty severe pectus, but he's an Olympic swimmer. And some people enjoy their pectus and either take their cereal in the morning or having a shot out of their pectus. And I guess those are the guys who don't want to have it repaired. This is the overview today. I'm going to present on the history of Pectus excavatum repair. And then Samir Pandya, he's an associate professor from Dallas at the Children's Medical Center there. He's going to present current management of Pectus excavatum. And then John Densmore, he's from the Medical College of Wisconsin, from the Children's Hospital Milwaukee, is going to present on current management of Pectus carinatum. And then Ashia Arshad, he's going to present on pain management of Pectus excavatum repair. Today, he was involved in a multi-institutional study recently, and he is actually a PGY4 resident who just is finishing his research years. And then we have question and answers at the end of each presentation and at the end. Questions can be asked in the Q&A window, and we're going to pick it up and then ask the questions and answer those questions. Thank you and welcome. We're going to move on to the first talk now. Guess I have to share again. Okay, moving on to the first talk. I'm a pediatric surgeon from Pittsburgh, from the Children's Hospital there, and you know, I do Pectus repairs, and I trained actually with Hulla in Hopkins, so I had always proximity to the history of Pectus, essentially. This started many years ago, and the terminology of this is really funnel chest, or from the German Trichterbrust, which means really the same as they were German authors in the early days of the Pectus. Pectus Excavatum, and then in difference to the Pectus Carinatum, when something is growing out, the keel chest or pigeon chest, where you see a picture on the bottom. Early history was recognized in antiquity, and Leonardo da Vinci has a famous picture you see there on the right of a guy who has some kind of a pectus. There was a classic paper by the great Swiss anatomist Johannes Bauhin. He described the clinical features of pectus, really dyspnea from pulmonary compression as well as cough, around 1600 already. And the ileocecal valve is the Bauhin's valve, if you recollect your anatomy. And then Epstein's anomaly, after Wilhelm Epstein, he wrote Über die Trichterbrust, which is German about the pectus, essentially the funnel chest, in 1880. So famous people picked up on this early and reported on it. There was a famous student, medical student from Vienna, who really traveled all Europe. And this was around the 1880s. And he became quite famous because he presented his sunken chest that was quite extreme all over Europe and made money like this. And there were 6 medical reports and papers written about him, describing essentially the anomaly. And one of the papers by Zuckerkandl, the Zuckerkandl's organ, another famous author. So it's a lot of history and historic people involved. And Epstein really wrote about 5 patients and coined the name funnel chest, Trichterbrust in German, in those papers. Sometimes it was recognized as an occupational hazard, like the Zapatero de Thorax, the shoemakers, chest, because they were, I guess, leaning forward, pushing into their chest while working on the shoes, and developed the Pectus Excavatum during their work days. And people thought initially this is an overgrowth of cartilages in this area. Heredity was recognized really early on, almost 200 years ago, as well as the connection to Marfan syndrome in the 30s of last century. The treatment, there was not really a treatment at the time. It remained limited to fresh air, breathing exercises, aerobic activities, and some lateral pressure. They advised people to sleep on the side. Surgeons really could not operate on the chest. There was a taboo at the time because they had no concept how to prevent the lung from collapsing. And the chest surgeries really started about 100 years ago, with people initially just resecting single ribs, and then miraculously the dyspneic patient improved after this procedure, at least in his medical report. And then the great surgeon Ferdinand Sauerbruch, the big professor, he was a German surgeon in the 20s and 30s who became quite famous, practiced in Berlin. And he resected a bunch of cartilages as well as part of the sternum for one of those patients. And quite interesting, the patient was incapacitated by his breathing efforts and his palpitations, and he couldn't work in the watch factory where he had to do fine movements because of his breathing. And then post-op, after all this was resected, his heart could be seen pulsating onto the muscle flap. So he just resected this area, and he was able to work and married 3 years later. And so surgeons like Sauerbruch and others resected ribs essentially at this time and part of the sternum, and then put patient in traction in the hospital usually for 6 weeks or longer to have it heal again. And his technique soon became known all over Europe, this is the great professor working on the chest. And here you see one kind of a poor patient on traction for now 6 to 8 weeks in the hospital to have his chest heal and not to sink in afterwards. In the US, there were famous names like Oxner and Michael DeBakey, who published their experience in 1939. And people at this time thought that the traction of the diaphragmatical sternal ligament, really below the xiphoid, were causing this. So always all tissue had to be divided to the diaphragm as well as to the abdomen, which is a misconception as we do now. But at the time, they thought of this. And here you see a picture from DeBakey, where they also used traction to have people heal afterwards for a long time. The modern era, as we call it, really started already in 1949 with a guy called Mark M. Ravage, who really described the principles of Pectus Excavatum surgery. And he removed the deformed cartilages. He divided also that xiphi-sternal articulation. And then he performed an osteotomy on the sternum. And then afterwards, the position was maintained of the sternum so it would heal and not sink in again. And he really resected here, this is from his original paper, ribs which were poking in, so to say, and cut on the lower picture the ligament, and then divided the sternum higher up and then fixed it initially only with sutures in a better position, essentially. This was done in small infants most of the time, because this was all cartilage and it was easy to do. And the indications, as they said, was cosmetic, number one. Prophylaxis is better than cure, so do it early and they grow okay. And then physiological, because they realized that patients who are older had exercise intolerance as well as arrhythmias in part. Ravage was an interesting guy. He was a great professor really at different institutions, a historian and teacher, as well as an innovator. And he also is one of the fathers of US pediatric surgery, which was not a recognized discipline at the time. He was born in New York City to Russian immigrants, so he spoke about 5 languages, Russian, English, and a bunch of European languages. He did not get into Harvard Medical School, and that was his comment to that, and then graduated from Hopkins and stayed in Hopkins on for a while before he went to several different hospitals, coming back to Hopkins for a long time, and then ended up in Pittsburgh and was 20 years really the surgeon-in-chief at the Montefiore Hospital, where he operated on adults, but also on children at the time. And he published an editorial in '69 where he focused a lot of his work on children at the time, that it should be a known specialty, which then actually happened afterwards, also due to him. He was a very influential surgeon, and he was known for his incisive mind, intellectual integrity, and productivity. And he really had an extraordinary dedication to teaching. He conducted teaching rounds from the hospital bed, laughed with himself, but he was a tough interrogator at M&M, as I read in some old reports. He was a true general surgeon, but also operated on children. And he was a big innovator. And he actually was on a trip to Russia, where he met a surgeon called Nikolai Amosov, who used staplers for pulmonary surgery. And he actually obtained one of those from the original factory in town and was able to kind of almost smuggle this out of Russia. This was during the Cold War, and then collaborated with the US Surgical Corporation against a lot of pressure in the US of surgeons who were used to use their hands and suture and didn't want to use a staple device necessarily, and introduced the first staplers to this country. He also actually advocated for hydrostatic pressure, reduction of intussusception, which at the time those children were all operated on. There was a very high mortality in those days. And then they essentially used a contrast enema or pressure enema to reduce this and saved a lot of lives for children. This is the first stapler he brought from Russia. On the top picture, they had to be loaded with a stapler for every fire. And on the bottom is really the first series of staplers he produced with his, the company. And I must say they look pretty sophisticated, even an EEA stapler already. So after Ravage, surgeons noted poor long-term outcome. The chest would cave in again, essentially. So we needed some posterior support to maintain position of the sternum until it has healed. And so people use different methods, metal struts. Robisek, he used actually the hammock repair, where you place the mesh underneath, and he did this until recently. It's probably still used in single institutions for that, to really stabilize this. Ravage was a famous European surgeon in Germany who had his own method, wrote a textbook, and a lot of influence. So this was a lot used in Europe with those struts. The sternum was wired to let it heal. And this is how that looked on the picture of Ravage after this repair. But note, they still operated on small children, essentially. And then as surgeons became more minimal invasive, they became less radical and really cut less and less also on the chest. And then the modified Ravage procedure really came along. But it was still advocated in very young patients. Alex Hulla was in Hopkins, and he was a graduate there also, like Ravage. And he was the chief of surgery in the pediatric surgery in Hopkins for many, many years, from the 60s to the end of 90s. And Dave Sabiston has started that before he went to Duke for 3 years. And he contributed a lot to the pediatric surgery literature. He had the first trauma center, trauma system really in the state. And he did a lot of Pectus surgery because that's where Ravage initially described the procedure. And so the Hulla Index is something we use nowadays to measure how deep a pectus is. So the insurance also would cover it. They cover it only at a certain level. And at the time, for this paper he wrote about it, GPS is General and Pediatric Surgery, a medical student asked, how do you choose patients? Because patients walked in his office and somebody said, okay, we're going to repair the pectus, and somebody said, we don't. And so there was not really any scientific method or number. And so then they started measuring essentially the Hulla Index. When you look at the line transversely, and then the deepest point essentially, and they created an index or quotient, and they looked at all the patients he had operated on and all the patients he did not. And they found if they draw a line at 3.25, it's kind of a cutoff. And so that number we still use nowadays, and the insurance companies based on this one paper. Meanwhile, we try other ways to evaluate this, but that's still been used mostly. Hulla also noted that some of those patients who got operated on early, their chest wouldn't grow later. And the patient, like on the right picture, this is the patient who had a pectus repair earlier, and now his chest doesn't grow. And there is a syndrome called Jones syndrome, which is a patient on the left, on the picture on the left, where the chest doesn't grow and those patients suffocate. Nowadays, they get rib extension procedures. But so they called it acquired asphyxiating chondrodystrophy because people were operated on too early. And Pena, the famous pediatric surgeon who looked at colorectal malformations mostly, but he did a research study in rabbits, similarly operated on them early and saw that the chest wouldn't grow later, and published this. And based on those papers, surgeons stopped doing early repairs, and pediatricians really stopped referring patients to the US surgeons. And commentators in the 90s, pediatric commentators said, you know, it's been evident for a long time that far too many young children have had surgery for Pectus Excavatum. They thought it was malignant. And I've stormed for many years against surgeons who have published large theories. The operation is worse than the disease. That was the opinion in the pediatric world. And then Donald Nuss came along. And he also, he noticed that rib cartilages are flexible, especially in young children. They're malleable and they're soft. And even older patients can still reconfigure their chest. Look at the barrel chests when you get older. And so they also noted there are braces, for example, in teeth or others, who can actually, scoliosis, for example, who can bend things back into place. And so he wanted to just bend things because of that. And he initially in the 80s really experimented with his patients. I mean, here's a bar he uses on the upper picture. That's a midline incision. And those bars were too soft. Those didn't work. And he finally got a company to support him in the early 90s who made bars which had different ends and were really stiff, so they wouldn't cave back in. And he really practiced on on those, I mean, practice, I must say, and repaired those patients, only him. Nobody else in the world really did this. And he developed different instruments until the end of the 90s and did a lot of improvement to this procedure. And the technical principles of the procedure is really putting a bar behind the sternum, turning the bar, and the bar sits on the side of the chest wall. This image on the bottom is a little bit wrong because the bar really sits on the top of the ribs, not kind of more on the side. But there was his principle. And he published a paper in '98 after he'd really done this for almost 10 years and nobody else in the world. And he really had improved his technology for so many years and had this company make instruments. And this was an absolute disruptive technology. I mean, I was just starting to do surgery at the time, was in Germany. Within 3 months of this paper, there was a workshop and Nuss came and taught it to people in different countries. It was an amazing ascent. And it was widely adapted after his first report, which is the first report, a 10-year review. So he'd done this for 10 years and nobody else knew about it. Sexy concept, you don't resect anything, you just bend things, a lot of pressure, peer pressure. And then the pediatricians would send patients again because you don't resect anything and things don't have to heal anymore. And he became really famous, US News front page here, a chest popping bar. It's really a sexy concept. That's Nuss working on one of his procedures. And here's the patient after the procedure, mother can't believe it. And he's back to being a beach boy. So it was a really impressive event in the world of Pectus Excavatum. There are other techniques which kind of have some kind of a niche status, if you so want. There's a vacuum bell. This is actually the inventor himself with a vacuum bell. You can use mostly on younger children, but you can't suck on it all day. They have to go to school. So this is a downside. The great inventor, Michael Harrison, really founder of fetal surgery, thought of a magnet and pull out this. This is also still in transition. Essentially, those projects and research is being done, as well as for Pectus carinatum. Anything coming out, you brace and push in and can reshape. And others thought of techniques like pushing things in for carinatum and fixating it. This has some downsides. We'll hear a little bit about this later. And then there are some thoracoscopic techniques where you resect ribs from the inside or edges of ribs. And this is not really usable for larger deformities, more like for single rib deformities or things like this. And everybody wants to be a superhero in this world. And this is the window washer at Pittsburgh Children's. And those are his colleagues cleaning the windows. So we're going to hear about Pectus repairs in this webinar now and what is actually done today to fix those children. Okay, thank you very much. Samir.
That was excellent, Stefan. Thank you for such a thorough talk. So far I don't see any questions on the Q&A board. Okay. Just to remind everybody that if you do have questions, please put them in the Q&A and we'll try and answer them that way.
Why don't we just move on to your talk then?
Perfect. Okay,
so
Dr.
Samir Pandya, he's a pediatric surgeon from Dallas, and he works at the Children's Medical Center there. And he did his residency in New York Medical College, Westchester Medical Center, and his fellowship pediatric surgery at Emory.
Thank you. Can you all see my slides?
Yes.
Okay, excellent. Well, Stefan, thanks for the invite. Thanks, SAGES, to the program committee and the RAF committee of SAGES for inviting me to give this talk. I really enjoyed your talk, and you've gone through a lot of the stuff that there'll be a little bit of repetition on this. I'm going to focus more on just the Pectus Excavatum business end first. I don't have any disclosures other than I am still in debt from medical school loans. The objectives today, just wanted to, for us at the end of this talk to be, for the audience to be able to identify and characterize Pectus Excavatum objectively, and then describe in general what the preoperative evaluation would be, and then go over in just a brief overview of the current and novel techniques of surgical repair for Pectus Excavatum. I'm not going to go too much into the postoperative outcomes, simply because, as you can tell, we can probably talk about Pectus for the entire day if we wanted to. So, so moving forward, let's just start with a case. You have a 14-year-old, otherwise healthy male who presents with worsening dyspnea upon exertion. He's unable to keep up with his peers. He affirms some substernal chest pain or pressure that is exacerbated by exercise. And he's extremely self-conscious. Always has his t-shirt on, always has a sweatshirt on even. And he also wears his t-shirt at the pool. So he comes to see you in the office. And in the office, this is what his chest looks like. Technically, this picture is in the operating room, but bear with me. So this is what his chest looks like. I think Stefan has gone over very thoroughly that this would be the funnel chest. And here's a little photo magic with a popsicle stick, so you can see the shadow that gives you the idea of that this is a funnel chest. So I know that we did have somewhat of an audience response system, but I was there. I failed in sending those questions in early, so I apologize. But which of the following tests would be useful in assessing the severity of the defect? So there's treadmill stress test, computed tomography or CT scan of the chest, PFTs, and echocardiogram. So for this example, I am saying that it's the last three, and the stress test is not necessarily required. That said, there are situations in which you could get that, but you don't absolutely have to. So the appearance of the excavatum is typically due to two factors: the degree of posterior angulation of the sternum, and specifically also the angulation of the cartilages as they meet the sternum. So now that we've seen this patient in the office, what are the things that we should try and get to in terms of the patient interview? What pieces of information do we want to elicit so that we can then determine suitability for surgery or correction? So first thing that we really want to talk about is symptoms. Do the patient have pain? Do they avoid physical activity? Are they unable to keep up with their peers? Are they extremely self-conscious? In our example, this patient was extremely self-conscious and would not take his shirt off even if he was at the pool. And if you recall, he had difficulty keeping up with his peers as well, and affirmed substernal chest pain. In addition to this, we also want to know underlying conditions such as cardiac conditions, any kind of murmurs or issues with the valves, any kind of pulmonary conditions, asthma, reactive asthma, airway disease, or history of connective tissue disease. So that's somewhat difficult to ask sometimes, or you can ask and the patients and the families may look at you and they say, how would I know if I have a connective tissue disease or something? So the way I elicit that information is typically I ask the question of, is there anything that you can do that you consider to be like a trick, like you're a little more flexible than somebody else? Can you, do you feel like you can turn your head around 360 degrees or something? And invariably, sometimes somebody will say that, oh yeah, I'm super flexible, and that all my family's been such, and that starts triggering suspicion for a connective tissue disorder such as Marfan's or Ehlers-Danlos. The other thing that some people also like to do is when I mean some people, I mean myself included, is I look at the arm span of the patient and I try and relate that to their height. And if they have a significantly longer arm span, that also gives me, clues me into a suspicion for Marfan's. And sometimes they may know that they have a genetic disorder or they may have a genetic disorder. But most importantly, after all of this, is to figure out how interested are they in correction and thereby surgery. Sometimes they just want to come in and they just want to know that this is a benign process and that it's just, it may get worse as they keep on growing and then eventually may plateau once they get into adulthood. Or they just want to get some more information about before they weigh in on whether or not they want surgery. Or they were just, they really didn't care and the pediatricians sent them for an evaluation. So not every patient that we get sent or referred by the pediatricians results in a case. So in Dallas, every patient, once the patients have expressed interest to undergo surgery, and if the defect is severe enough in our subjective opinion, we will then follow the following protocol. Now, I want to pause there and talk about this whole subjective opinion business. So it is interesting, and I think it's difficult to really predict who's going to have meet that Hulla Index that Stefan talked about. We've done some work here retrospectively and are ongoing doing a prospective study to see if there's any kind of what the correlation is for bedside assessment of the physician estimated depth. A lot of people have poo-pooed that idea that, you know, estimating it at the bedside can't really give you enough information, but there's a dearth of data out there to tell you exactly how sensitive or how specific it is and how that correlates to male versus female versus obese versus non-obese patients. So at present, we don't use a bedside screening tool. Our screening tool for obtaining a chest CT and the above aforementioned test is really if the patient has expressed interest and we subjectively can tell that this seems to be a severe enough defect. In the interest of some kind of interaction and making this a little bit more interactive, I want to poll my fellow panelists here. When you have a patient that comes into the office, where do you draw that line that Dr. Haller did? How do you go through that? When we will start with John, how do you approach that?
That's a great question. And I think, you know, nice presentation of the workup. I think, so there's a pretest probability, I think, that by the time a patient and their families reach your office, that they're seriously, that the child's life or the parent's life is sufficiently affected that they are willing to even entertain surgery. So there's already a slight threshold crossed, the fact that they're standing in front of you. You know, I unfortunately, the current state of this is that there's a Hulla Index drawn in the sand by third-party payers at 3.2 that is a pretty hard line. And so, you know, at our institution, you get a Pectus protocol MRI that actually gives you that Hulla Index and makes an argument for right ventricular impingement by the Pectus, which makes a compelling argument for the third-party payer, even though I have very little medical concern about that. Yeah, I think. So
do you? So let me just interrupt you there. So John, do you? So would it be safe to say that by the time the patient comes into your office, and if they are willing to undergo surgery, that's a automatic that they're going to go through your workup?
I would say that in my practice, that those conversations can start very early, even at the age of, I have some patients 2-3 years old with profound pectus. And we're really there as surgeons to provide an education of the family and the patient. And some 25% of the folks that we meet are never going to come to surgery. I think the hard job of the surgeon is actually to parse out which child is going to fulfill their personality, their confidence by having had an intervention. And the whole biophysical, biopsychosocial impact cannot be underestimated in this. And we spend a fair amount of time talking about those things. I guess I have some insight in that as because I grew up with pectus and I went through a Ravage, and that's provided me some insight into how that impacts one's view of self-health and vulnerability, and also the dynamic that can exist between parents and children, sometimes who shoulder some guilt and want to see an improvement or a correction for their child, which is a very dangerous situation to be in. So I think, long story short is spend the time to get to know your patients, make sure that the motivation for surgery comes from the child, and never intervene before you're certain of that. And then the last thing I would say is that, to leave them with a statement of health. Well, there's demonstrable changes in restrictive breathing. These kids can get out and play hard, and some athletes who are really well adjusted would rather not have their life interrupted for an intervention. And to them, I say, go live your life. The hard part is that there's a window in which we can do a minimally invasive repair that works better. And so I try to employ the parents as ongoing discussants of, will you have appreciated an intervention 10, 20 years from now, and to have those discussions at home with the kids. So there's a whole lot there, and I think we're trying to maybe oversimplify, but I think I do want to stress that I think that having a good appreciation for where the motivation's coming from and why portends a better surgical outcome and a better the better, it's really for the best outcome for the patient and their life. I said a lot there. I'm going to be quiet now.
Stefan, how do you approach it?
I mean, they have not too much to add what you said. There's a group of patients I see who clearly don't need a repair, whereas a minimal, they come more or less sent from the pediatrician, who just need reassurance. And but otherwise, you do have to approach it like he was just really eloquently pointing out, I must say. There is a lot of patient satisfaction, I must say, after this repair. So if the patient really wants it, and it's a pectus you think it's pretty severe just by looks, it's usually worth it if everybody's on the same page. Yeah. Then there's this group where it's minimal, obviously, and it's not worth it, and nobody wants it.
Yeah, when I was a fellow, a couple of my staff had, I asked that same question that medical student asked Dr. Haller, that how do you know? Like, this guy, you're going to get a CT. This other person, you said follow up in a year. How do you know that? Where do you draw that line? And so Rich Ricketts, who trained me, was one of the people that trained me. He said that he used a popsicle stick and measured 2 centimeters as a depth. And that was his gauge. And if it was 2 centimeters or more, he would get the CT. And if it was less, he wouldn't. But I could never find a paper that proved that. And so last year, I did a retrospective study in which I used historical scans that we had, and I estimated the depth just on the CT scans and correlated that to the Hulla Index. And I found, interestingly, that if I had like 17 millimeters or so, I had 80% sensitivity, especially if they're not obese. So now I've been collecting that data prospectively, and we'll see where it goes.
So Samir, interestingly, at Hopkins, you know, I trained with Colombani, you know, and Hulla was before he was retired at the time, but he used that caliper, you know, he used the caliper, and it was kind of 2 centimeters too. It kind of was a cam number. He used the caliper to measure, and it was kind of a ball.
I love these. These are cool anecdotes. What makes me cringe as a former patient is anything that's going to be touching the anterior chest wall in your evaluation. Your patients aren't going to tell you, but that's incredibly uncomfortable. So there are optical devices you can download from your phone that actually can make a surface tomogram based on just moving your iPhone over the surface. And you can come up with a Hulla estimate that's pretty good. But I try to refrain from actually physically touching the center of the chest. Anything inside the nipple line, I try not to touch. It's almost like a groin, if I can give that analogy.
Interesting. Well, okay, I'll keep going. I just wanted to poll you guys, and Syed, don't worry, I'm going to ask you questions too. Okay. So we've gone over, you know, the Hulla Index, and here's a little picture of how to get it. What I did learn, and I always learn when I do some of these things, what I did learn from you, John, is that you all do Pectus protocol MRI, and I actually like that idea a lot. We do the cardiac MRIs sometimes, but I'm wondering if we should start doing a Pectus protocol MRI for more of our patients instead of CT. So thank you for that. I do know some of our colleagues estimate the Hulla Index just on chest X-ray. I think I had heard that from, I think Casper had told me that he does that in LA. And which actually makes sense, because at least from these, from what I've seen, the insurance companies don't really care where you got the Hulla Index. They just want the Hulla Index. So unless you guys have heard differently. The next thing that we do for the workup is pulmonary function tests. They get the PFTs, and there's a decrease in the FVC, FRC, but really this is not the straw that breaks the camel's back, if I were to say that. You know, it's just it's good as an adjunct, and it's good to have in your supporting documents as you try and get this approved for the family. But I don't think it's a vital piece of information, because I bet that many of them don't even know how to interpret this data, to be quite frank. And then if you are sometimes faced with a situation in which you want to prove functional impairment, and so in that situation, you may get stress echocardiograms and positional echocardiograms. We get an echocardiogram on all our patients along with the EKG, just to see if there's any compression, if there's any of the ventricle. We'd like to document that. And then also there are these rare electro anomalies that patients can have, specifically Brugada syndrome. And so you can be faced with sudden cardiac death all of a sudden. And so we've made it our practice to get an EKG on all our patients pre-op. So is that what you all do as well? Oh, before I do forget, we also do allergy testing on all our patients now. I know that historically we used to do it just on those who have seasonal allergies or significant allergy history, but seems like an easy enough test to get that we just get it on all our patients now. Stefan, is that along the lines of what you all do in Pittsburgh?
Always allergy testing. You know, if you have a stainless steel bar in the chest and you have a nickel allergy, you get, I mean, those pleural effusions, wound redness. It's really hard to deal with. And we usually do an exercise PFTs, you know, on the treadmill.
Mm-hmm.
EKG.
And EKG as well. Okay. And what about you, John? What do you guys do?
You know, interestingly, we looked into the allergy testing and brought in some invited speakers. The problem with the cutaneous testing is that the CD4 T cell response cutaneously doesn't really mirror what's going on in the deep tissue. And that, coupled with the fact that the vast majority of bar allergies can be treated successfully with a short pulse of steroids and antihistamine, I abandoned that about 4 or 5 years ago.
So you put in stainless steel bars in everybody then? You don't use titanium at all?
We sure do. Now I do ask about things like, you know, cutaneous metal allergy, but you know, we've learned from our orthopedic colleagues that the cutaneous testing doesn't really predict the deep tissue reaction. And I have had a couple cases of bar allergy that we've successfully navigated with. There's a published, I'm happy to share with you later, but it's a published short course of prednisone with some antihistamines and managed to get those folks through their full 3-year duration. With regard to physical therapy, I think it's great. You know, we do it often post-operatively. There's certainly no harm done, and the Clovibel is kind of fun to put on pre-operatively and say, hey, this is what your chest may feel like post-operatively. Sort of a management of expectations.
Yeah.
These are great points you bring up.
Yeah, I just thought that we might as well just make it into like a crossfire panel right now, right?
I mean, I do use the vacuum bell usually on patients, you know, when you see them earlier, like 9 years, 10 years, they're pretty malleable now. The vacuum bell can really pull it up nicely. The problem is obviously the wear time. If you wear this thing a lot, it actually can help. And I'm sure over a year or two, it actually corrects it. But the problem is they have to go to school. They can't go with this to school, so they can wear it half an hour in the morning. And they have to be really persistent and motivated. And that's really the crux on it. But I think if it's worn a lot, there's some patients who I'll give it to every year. And unfortunately, they have to pay out of pocket. It's in the range of $500. But it can work for those patients, but it does require motivation from everybody.
Like everything, right? And you can go to the gym, but just going to the gym itself doesn't work. You actually have to lift the weights, right? So similarly, you can buy this device, but you actually have to use it, and then it may actually work. So yeah, so the vacuum bell is kind of nice. Thanks for that segue. So this is a little device that comes in variable sizes. You can see that on the upper insert there. And they talk about a treatment regimen of about two-hour sessions a day. But I think it's one of those things that you can't overdo it, but you can certainly underdo it. And of course, it's much better in the younger patients. As we talk about this younger patients, you know, Stefan, you had said something. You had mentioned about Jean's syndrome and how that was specifically in the younger patients. As there was a criticism from who was it? The AAP president or something? Was criticized.
Initially, you know, for 50 years, this was repaired in infants. There was a procedure. You know, everything is cartilage. And then some of them, the chest didn't grow. And
so interesting question I have then in that is that there is some data out of South Korea now that is encouraging repair earlier, somewhere in the range of 7, 8, 9 years old. Whereas in the US, we've historically gone from early to then a little older to 14. Average age, the last I checked, was about 14 that we're doing it. So out of curiosity, what do you all think? I'll go with John first.
Yeah, it's a great question. I think the key always falls back to motivation for me. And if you kind of accept the caveat that most kids really become self-aware at around 8 to 9 years of age, it's hard for me to conceive that an intervention before that is really going to be of psychologic benefit.
So what's the youngest that you do it? What's the youngest that you?
I think 12 at the youngest. I really, when we look annually at our average age of intervention, it was 14.3 years. I just looked at the data this morning.
What about you, Stefan?
Well, I have no rush, for several reasons. One is what John was just saying, self-awareness, motivation, who is a candidate. Number two is, I don't want this patient to grow rapidly, early puberty as well as width, so I usually wait until the initial growth spurt of puberty is over. And number three is you don't have to do this procedure early, really. I mean, you don't burn any bridges by doing it a little bit later. And and the fourth reason is really, if you do it early in the 7-year-old, you have the bar in 3 years, remove it, they still grow, it may recur, may come back.
Yeah.
So it's not, there's no need to do that.
Yeah, agreed.
Done nice maps of bone mineral density by age, and you really want to capture those 3 years between 14 and 18 as the sweet spot.
Yeah,
but there is flexibility on the other end.
Exactly. If any of the participant has any questions, use the Q&A and give us any questions, because you can't ask them verbally.
So
I was going to add that.
Yeah, go ahead, Simon, please talk to us.
Here in Houston, it's kind of a similar pattern, 12 to 14. However, we recently looked at the NISQIP pediatric data, and that's the US-based hospitals. There's still a fair percentage that are doing these operations and procedures under the age of 10. I'd say when I looked at the data most recently, still something around 5%, maybe a little less. It's hard to say what the clear indication is from NISQIP data, but it's still being done to a degree.
Interesting. So you were able to get that out from the NISQIP data, which is interesting to me.
Yeah, just based on procedure codes. So it's difficult to say if they've done the operation for not a true Pectus Excavatum, but they've coded it as such. So there's a bit of limitations to that. Obviously, some of the big centers that do hundreds per year may have more data on that, but it's still being done to a degree in younger kids. However, still fairly rare, as you noted.
Excellent. Well, I'm not going to go too much into the Ravage procedure because I think John's going to hit those highlights when he talks about Carinatum. So, but what I do want to say is essentially go ahead.
I think we also have to speed up a little bit.
Oh, okay. I'm sorry. Okay. I'm taking too much time. I'm going to move. Okay. So here we go. This is a little intra-op picture of raising a pectoralis flap, a resection of the cartilages, a little cartoon of doing the sternal osteotomy and sometimes you can put a retrosternal bar. The NUS procedure, as Stefan had talked about, essentially we do 2 3-centimeter incisions, the mid to axillary line bilaterally. Most of us, or many people, use thoracoscopic guidance now. I'm hesitant to say that it is standard because I do know of several that don't use it. And so be that as it may, the pros and cons of which can be debated. In the interest of time, we won't. Essentially, you then dissect the pericardium away from the underside of the sternum. You have some of the things that you can use to improve your safety is the use of a sternal elevator, and then establish the critical view of safety as has been described by Notrika and others before. And then you eventually place a contoured transthoracic retrosternal bar. here is a little cartoon picture of how that goes. Here's a thoracoscope. In this picture, you see that it seems as though that the scope port is separate from the axillary incision. The way I do mine, I put everything in the same incision, and it works out just fine that way. But there are people that make a subxiphoid incision and do that retrosternal dissection through finger dissection, and then put the scope in through there if they need to. And so now we'll go back to that patient that I'd mentioned. So this is his, they've gone through all their testing, and this is the findings. So now we're in the OR. We have a little bar that's been bent to make it look nice and flat. This is an old picture. So this is when I was using umbilical tapes across and doing it blindly. I no longer use the umbilical tapes. But when I did, I'd make sure I had two because invariably one would break. And then we use a chest tube to bring the bar across. And then you flip it, and then you close your incisions, and that's your correction after you're done. So as you do that, most complications for the nuts procedure, pneumothorax can be a complication, but it also can be a normal finding. Most of the time, bilateral apical pneumothoraces are normal findings. But every so often, you do have the situation in which you've injured the lung or the lung parenchyma, and so then you can have that. And that can be kind of a problem because essentially now these patients have acquired a buffalo chest. Syed, do you know what a buffalo chest is?
I haven't heard that term.
You haven't heard that term. I figured you hadn't.
That's what you get when you actually do lift the weights at the gym.
So buffalo chest when the two pleural cavities are combined in one, and so then they just if you shoot an arrow to a buffalo, they both is one combined cavity, and then there will be a tension pneumothorax. So hemothorax, cardiac and pericardial injury. I've arranged these in order of intra-op, post-op, intra-op, and then moving on to post-operative. But most common would be probably, I would say, infection, even though that is kind of rare, and bar dislodgement. So here is a video that I thought people would like to watch, and Stefan corrected me well, I got this video from a luminary in Pectus surgery by the name of Hans Pillegard. I call him the Bono of Pectus surgery. He's a Danish surgeon. He wears glasses like Bono, and he's quite impressive that way. But he was very clear that this is not him operating. And I never knew who it was until Stefan sent me an email today telling me who it was. But it doesn't matter who it was, but even with thoracoscopy, this can happen. So I'm hoping you all can see this. This is a thoracoscopic view.
This is an unbelievable video.
John, have you seen this before? Here we go. The most interesting part is that they keep going. So the lesson there is that obviously,
yeah, sorry. At this point, I'm calling for the sternal saw, 6-O-proline, and bypass access, please.
Yeah.
So this, Samir, this happened to a adult thoracic surgeon in South America.
Yeah.
And they did a thoracotomy, and actually, not a sternotomy, a thoracotomy, and actually repaired it.
And they saved the kid. The kid did not die.
No, and this kid died, and it did not die, and they repaired it essentially. And there's obviously a low pressure system on the right, ventricle, what you saw there, but this is in a scary video, seriously.
And the reason I bring that up is that this is, a lot of people think that this is purely a cosmetic operation, and it is not. As John has spoken, that these patients have significant issues. They have biopsychosocial issues, and at the same time, this can be a significantly risky operation for them to undergo. And so that message has to be relayed very clearly to the patients and their families. And we only proceed with this operation when everybody's on board. This doesn't happen often, but if complications like this do happen, they can be devastating. So that's the reason I bring that up.
Surgical procedures, in the early days of the NUS procedure, this happened a few times in the US as well as in other countries. And NUS made it a mission, and others obviously, to perform this procedure safe. And that's where the new different instruments come in, as well as the different steps and so on. There are actually some anecdotes I could tell, but it's fine right now. There's a question from Stephen Borenstein to Samir. In your cartoon of the chest, that was entered lateral to the pectus ridge. But NUS describes it to go in there medial.
Now, let me go to that cartoon that you're referring to.
He's actually right. The cartoon is wrong. And so it's important to point that out.
The cartoon is wrong on that.
Well, I mean, that's oversimplifying it a little bit on both ends. I think, in my mind, it's simple physics. You're looking for the most anterior intercostal space that corresponds to the deepest portion of the pectus. It still allows you bar stability. So, yeah, I think that's the simplest way I would put it.
But see how you enter the chest on this thing kind of lateral to the ridge. It's obviously not right. Anyway.
I enter more medial, and that's how it was described, and that's how I was trained. So this complication video that we showed, and then Stefan talked about the steps that we have taken to mitigate these intraoperative complications. One is sternal elevation. I found that to be quite useful. I now use a little device. It's called that is a self-retaining type of sternal elevator. It has a little cable on it, and I put a little tenaculum type of thing, and then elevate the sternum. This I use mainly for my really deep defects. The ones that are not that deep, I don't think really need to do it. And then the other is developing this whole critical view of safety, in which you have a nice wide dissection of this retrosternal area, so you can safely go across and make sure that you haven't hit that. Notrika has a great article for anybody that hasn't read this and is interested in reading this. In Seminars of Ped Surgery in 2019, he talks about the error traps in pectus surgery. I think it's a fantastic article, and I really encourage everybody to look at it. So in terms of outcomes, this is interesting study, large numbers, and looking at the outcomes with regards to having done the operation in less than 6 years old, 6 to 11, 12 to 17, and 18 plus years. And you can see that most of the failed surgery is when you have the patients to be much younger, as was alluded to earlier. So anyways, that's my brief discussion on Pectus Excavatum. Happy to take any more questions, and I'm sorry if I went over time. I hope everyone's enjoying the discussion.
Okay, great. So we'll move on to the next talk. There's no other question at this point, and we're a little bit behind time-wise. So we're just going to go on to Dr. Densmore, who went to residency at the Medical College of Wisconsin, Milwaukee, as well as fellowship. And now he's a big attending there and an associate professor and a pediatric surgeon. And he's going to talk about the Pectus Carinatum.
Thanks, they promoted me, so I get to say professor now. But really, it's just that they couldn't get rid of me. That's honestly the truth. So this is a subject that's near and dear to my heart, no pun intended, having been through a Ravage for excavatum. I'm going to talk about Carinatum today, hopefully, if I can advance my slide. Here we go. We're going to talk about natural history. I want to leave you with an approach for evaluation of Carinatum, understand available interventions that are out there, some of which are not available in the United States, but you need to know about them, and then key outcomes and importance of really a multidisciplinary approach. So, you know, if you consider all chest wall anomalies, the carinatum, or the keel, it means keel in Latin, meaning the protuberant chest, and there's a few different varieties of that we'll talk about. They really make up a minority of the chest wall population that you're going to see in clinic, probably less than 10%. Still a 4-to-1 male preponderance, just like you see in excavatum. We do still see penetrance through generations, and you know, our patients get screened using the Ghent criteria, which you can Google easily to screen for Marfans, and there's Baton scoring for hypermobility. Not everybody gets referred for genetic evaluation. We screen in our clinics and kind of do that ourselves and then refer on. But there is this 5 to 10% incidence of heritable or ill-defined connective tissue disorders that are never actually going to be carry a nice name diagnosis. Often this is seen with growth spurts in puberty, just like in excavatum. We talked about when calcification of the sternum occurs in the chest wall, and that affects your approach. And I always leave, you know, the first interview with a family and a kid is, I think, really important to set the tone, to acknowledge that you're there to address their worries and their concerns. And I always do leave them with reassurance, no matter how severe the chest. You know, this was a sentinel paper by Schamberger and Welch that reflects earlier work by Hulla, Ravage, others. But this was a paper from '87 that basically described 152 patients. And the reason that I think it's nice to present is it kind of gives you a sense of the people they were seeing in this 12-year time period. 17% of their population had carinatum, which is a little higher than you'd expect. And you know, none of that's really changed with time. Interestingly, spinal asymmetry and scoliosis is accompanying this diagnosis about 10%, and musculoskeletal anomalies are something to screen for and pay attention to. The vast majority of carinatum is going to fall into this chondrogladiolar type, which is the classic keel chest shown in figure A there, where essentially the gladiolar segment of the sternum. Can you guys see my pointer? I don't know if is that evident? Yeah, okay. So here's your manubrium, and this is the gladiolar segment of the sternum. And so, you know, the carinatum, chondrogladiolar carinatum, is this prominence of this portion of the sternum. The xiphoid sometimes is almost sticking straight out at you as it's exaggerated by the sternal elevation. There are other types that are more rare, but the good news is that this is the most treatable type with a Ravage, and it's the most treatable type with a brace. And it's also by and far the most common type that you're going to see in your practice. There are abnormalities like this, which are more of a costomanubrial defect, where you get an aberrant fusion of the gladiolar with the manubrial portion of the sternum, and a high carinatum with sometimes a combined deformity distally. You can have asymmetry of this, where one side of the chest has a carinatum and the other is more of an excavatum with sternal torsion. So in terms of thinking about it, you know, the flavors of carinatum are somewhat more interesting than the excavatum, and I mean, there's just more to think about. So there are different flavors, and that's what I want to leave you with on that slide. So we screen for connective tissue disorders. We talk about anybody else in the family have a pectus of any kind, because there can be Carinatum in one generation and Excavatum in the other. There's been measurements of cartilage length in folks with pectus of both types, and found to have, you know, longer segments, overgrowth of cartilage, and that's hypothesized to be the pathogenesis. These are very rare sternal clefts that can be encountered in combination or appear as more of a chondral, bilateral chondral Carinatum, when in fact there's also a sternal cleft. So things like axial imaging are going to help you sort these out and plan for them. Interestingly, the surgical cure doesn't change a whole lot, even with a cleft. You're going to still be looking at a Ravage or a modification of the Ravage procedure to address those things. Something that you may see on pediatric surgery boards, Poland syndrome. You can get a field defect in chest wall development, you know, that occurs around week 5 to 6 in organogenesis, where you just wind up with a unilateral pectoral aplasia and a smaller hemithorax with the Carinatum or just missing cartilage. And those are fun cases to take on with your plastic surgeon and think about what's going to give the best correction in terms of the chest wall, and then subsequent tissue expanders to make up for muscle or rotational flaps. Slipping rib is something I want to throw out there. It's can accompany any of the chest wall disorders. Typically presents as a patient with vague, maybe abdominal pain. There's a maneuver that can be used to elicit that pain called the hook maneuver, and it's simply to use your fingers as a hook, come up under the 11th rib cartilage and lift towards the head. And if your patient reaches for the chandelier, then they likely have a dissociation of the chondral insertion on the sternum. And what happens is that that insertion then rubs against the intercostal nerves and gives them a really sharp pleuritic pain that's quite uncomfortable. And there's a few different ways to deal with that. That's not the purpose of this talk, but I just want to make you aware that this can happen. What's the physiologic import? Well, I show this slide. This is based on Pectus Excavatum, a nice patient by Robert Kelly and the group in King's Daughters in Virginia. They basically used some software that looks at motion, and mapped out preoperative chests with Excavatum and postoperative chests, and showed that by correcting the dimple in the chest, you actually increase mobility of the chest wall. And I think that that's true if you can imagine a piece of sheet metal that's flexible. If you take a sledgehammer and put a dent in that sheet metal, it suddenly becomes more rigid. And that's true whether it's an Excavatum or a Carinatum. So what does that mean in terms of breathing? Well, the thing to answer on your boards is there's going to be a small restrictive deficit defect that, depending on your lab, may or may not be able to demonstrate it. But there is inherently an effect, and others have shown earlier tachycardia and Excavatum. But Carinatum, there's a lot of room. So you're basically left with just a rigid chest wall, so maybe a slight restrictive effect. All right, so I'm going to talk about surgery first, even though most of your Carinatum patients are never going to come to the operating room. This is a modification of the Ravage procedure. It's had about 4 major modifications, the last by Coe and Welch, that I think really leave us with the modern interpretation of a Ravage. Ravage was initially a stage procedure, one side then the other, but essentially the idea of the operation is to reflect the pectoralis muscles, open the perichondrial sheaths, resect the cartilages that are abnormal, going as high as you need to, doing that in a mirrored fashion so that you have even forces across the sternum up to the level where the sternum is no longer affected. Freeing the rectus down below, and then setting the sternum by some means, either by wedge osteotomy with a chondral plate in there to hold it in the right position, or a wire or a bar shown here, and allowing the 9 to 12 months that it takes for that cartilage to grow back into the sleeve and stiffen the sternum, and then remove the strut at usually about a year. It's a fun operation. I just did one last week, 6.5 hours, very satisfying. The keys are getting the sternum anterior enough that you get a really nice repair. And so how you set that bar and stabilize it's really important. I'm just going to show you an example of a case that we did about 9 months ago of a young man who had been through a David operation for an aortic root. It was actually a valve sparing repair, but he has this ill-defined connective tissue disorder. Had been through a renal transplant almost due to severe unrecognized reflux disease. So you see some incisions here and a previous G tube here. This is this may be him, and it may be iatrogenic. But you can imagine when I saw this young man at the age of 17 in clinic, he was covered, withdrawn, depressed, and really unable to comply with even his immunosuppressive medications. We got him to envision a chest wall repair with the help of a psychologist, work through those things. He came to surgery. This is immediately post-operatively. You can see the correction here with a substernal drain. And this is the x-ray showing a K-wire, 7/64 K-wire that was used to hold the sternum in place. And then I just saw him in clinic recently, and this is the result. So, a well-executed Ravage. Now, he doesn't have a normal-looking chest, but his demeanor, and this is the part that I think is so fulfilling as a surgeon, is to see that he's out there working. He's engaged. He can more fully participate in his own life with confidence. You talk to these patients and you say, what's changed for you? And it's confidence. It's confidence in their own health, their appearance, and they can just carry themselves differently and better. So that's a Ravage. Now we had to surrender to this because when you look at that pyramid on the top of the chest, and I'm in clinic trying to deform that with my hand, it's taking about 25, 30 pounds of pressure to move it 1/2 centimeter. Way too stiff for what I'm going to talk about next, which is compression bracing. Paper by Aziz Khan and the group in Cincinnati, 2006, looked at 29 patients where they used this brace shown here. And this is, 95% of the Carinatum treatment that we're employing is actually non-operative. It's pretty hard to argue with no incision. Again, motivation. The only person in the room that can make this brace work is the patient. They're teenagers. We ask for initially a high wear time of 20 hours, usually for about four months or so. And then when the sternum is in position, they can back off to a lesser amount of time. And we continue that for 2.5 to 3 years during the time in which their skeleton is calcifying. And so it's what's cool about this is that it's self-regulating. So the straps on the side you see there are able to be ratcheted aggressively or not aggressively. But as they start to see a change in their chest, the patients are more motivated to be a little bit more aggressive and to wear it a little bit longer. And that's what you're looking for. Out-of-pocket expense. What's shown here is a static brace. It's the lowest cost option, $600–700 for the whole treatment. There are dynamic braces, which have essentially the same setup with a leaf spring on the front, and those run twice as much. But here's a dynamic brace on a young man. So it looks cooler. It's got the Velcro. It's got some of the snowboard bindings, you know, if that's what it takes for a kid to get engaged to wear it and their parents are able to make that happen, fine, you know. There are papers that tout that this will reach correction faster than a static brace, but in the end, it's the same duration of time and the same outcome in our hands. And it's great for chondrogladiolar carinatum. It's not going to work for horseshoe or other things. This is to kind of show you bone mineral content versus age. So the time at which we want to be bracing is also the same time at which you want a NUS bar to be in. It's this rapid period of growth or rapid period of mineralization that's happening, you know, from about age 14 to 18. And I'll spend a second talking about the Abramson procedure, which is.
Hey, John, can I ask you a question?
Yeah, please.
Yeah. I've been trying to find papers that have put the dynamic brace head to head against a static brace. Have you come across any?
I have not. I've seen historical comparison, static brace, shift the practice to dynamic, look, it seems faster. I don't, you know, again, I think because there's a retainer phase to the treatment that you have to abide in order to get a durable result. To me, it just doesn't make a whole lot of difference. I don't see the advantage. But I do believe that if you have a spring pushing on your sternum, that it probably does get it into position a little bit faster. For most of our families, it's not worth double or triple the expense for the same outcome. All right, so the Abramson procedure, invented by Dr. Abramson in Argentina, where interestingly, some severe carinatum defects exist in that gene pool for reasons that aren't well known. But out of necessity is born innovation, and here is application of basically a reverse NUS bar, which is placed under the skin and above the sternum and fixed to plates laterally that are essentially wired down to the ribs, and exert the same force as a compression brace just under the skin. Just hasn't been FDA approved. It's the same proof of concept that compression works. The major complication with this is that the skin can't adhere to the bar, which has made removal tricky in a few cases. In addition, if there are other proud cartilages, they employ sort of a local ravage to any individual cartilages that seem to be predominating after that correction. So here's the approach. See your kid who's motivated for the change. Is there worry about overall health and vulnerability? If you can compress the kid's chest by hand and they're approaching that 14-year time point, brace. This is going to be relevant for the vast majority of your carinatum patients who will have and it works even for asymmetric carinatum, even with a little bit of torsion to about 15 or 20 degrees, you'll still make a meaningful impact and get your patient in a happier state. For more severe rotational deformities in older patients, adult stature, I don't expect much from a compressive brace once you're in your 20s. So now we're going to be talking about a Ravage or a mini Ravage. For these rarer types, you're going to need an open operative approach. Think about sternal clefts, connective tissue disorders, slipping ribs, the rarer things. But most importantly, don't forget to address the psychological import of this intervention. I actually think it's the most important, both from your patient's well-being and the surgical outcome standpoint. just having lived through it. And this is my slide to those who haven't been through this. Your patients aren't all the same. Some are going to feel more vulnerable than others. Think about the center of any chest wall deformity as being another groin on the body. Keep your touching and looking to a minimum. In clinic and on rounds, be sensitive. Use Dermabond so you don't have to peel off dressings. Your patients may be worried about their own mortality. They may be worried about future dating and interacting with romantically. They may fear for their own children. Parents are often fearing for their children. They may feel guilty. There can be self-imposed limitations that the patients may not even realize. But you see them post intervention and they become more effusive, more gregarious, more outgoing. It can really be transformative. Ask about bullying. Ask parents, in isolation, how do you feel about this? I will say that beware of the parents who's looking to correct their child, especially if the child has no sense of derangement or deformity. That's a real warning sign, and that'll be a disaster. And think about cognitive behavioral interventions for both patients and families preoperatively. Super helpful in our multimodal pain strategy. And I do think a multimodal pain strategy and a multimodal approach is really helpful. I threw this up just as, this is a rarer case where, we have to think about Pectus Carinatum or Excavatum as a result of post-pneumonectomy syndrome. And this was a 5-year-old who had a CLE that underwent an emergent resection. And unfortunately, the left upper lobe was a casualty. And so we did a thoracoscopic completion pneumonectomy and then been deploying tissue expanders to occupy that left chest to keep ourselves out of sternal rotation, a smaller hemithorax, and the impending chest wall changes. That's with a plastic surgeon and a cardiologist doing an on-the-table TEE to make sure we're not compressing the heart. So I'm going to leave it there because I don't know how long I went, but I was going as fast as this Alabama guy can talk. So I'll be quiet. Questions?
Well, thanks, John. That was a great overview, I think. An interesting aspects from yourself, I must say. That's obviously valuable to any of us, first sight from a surgeon, patient, so to say. I think we should move on, to say I don't see any questions at this point in the chat or Q&A. So Ashia, why don't you move on? And as I said, he's going to be a PGY4 surgical resident in New Mexico, and he is finishing up 2 years of research in Houston.
Thank you for that introduction, Dr. Schultz. Honored to sit on this esteemed faculty panel as a resident. So thank you, SAGES, the RAF committee, and Dr. Schultz for the invitation. As you mentioned, I'll be talking on up-to-date pain management of Pectus Excavatum repair. The focus mostly on the minimally invasive or NUS approach, as that makes up a majority of the repairs nowadays. I have no disclosures other than to say majority of my research has been in this area, that being patient safety, opioid reduction, with a particular interest in Pectus patients. So just a quick little bit of background to follow up on our prior presentations. As far as Pectus Excavatum repair, we've gone through the history of it, but just to narrow it down, an open repair versus minimally invasive repairs. Regardless of what repairs patients are having, overall, still a painful surgery and a painful post-operative recovery for patients, regardless of their approach. This has been associated with long lengths of stay, high amounts of opioids while the patients are inpatient and even after discharge, and overall a long time for the patient to return to their normal level of activities, even once they've gone home. So let's put some numbers to this. Traditionally, when you looked at inpatient length of stay following this minimally invasive repair of Pectus Excavatum, if you look at papers about that are published 5 years and going back, typical average length of stay was reported 5 days in the hospital. How about opioids? So we all are aware of the opioid epidemic. Children haven't been spared from this. Overall, the number of opioid prescriptions, hospitalizations for opioid toxicity, and deaths related to opioid use and abuse have all increased over recent years. And even one paper showed that among opioid-naive pediatric surgical patients, 5% had persistent opioid use between 90 and 180 days postoperatively. And with repair of pectus, this being one of the elective operations tend to be a higher opioid prescriptions that are given out. This is an area of interest for these patients and their repairs. And how about recovery time? As I mentioned, these patients, even beyond their 5-day hospital stays, will tend to have fairly long recovery times to be able to return to their normal activity level. Most surgeons actually recommend the operation during winter and summer breaks for children. So as we're heading into the summer, it's actually heading into pectus season. So it just kind of gives you an idea of the recovery that comes with undergoing this operation. So what is traditional pain control that patients received? Well, our usual non-opioids and some opioids. And for the most part, again, looking 5 to 10 years and going back, they're receiving some sort of neuroaxial blockade, typically a thoracic epidural. This was pretty standard for patients to receive previously. So moving into what has been updated in regards to pain control for pectus patients. I do want to mention the caveat that the first part of this section is not unique to pectus patients. If you've been in training or in medicine for the last few years, you've probably heard a lot of these terms, a lot of these concepts, but as we move through the different topics we'll hit on, we'll get to the aspects that are more unique to pectus patients. So where does this start? It starts actually in clinic. It starts with setting the expectations with the patients and the parents. Again, these are pediatric patients, so although you're treating the patient directly, you're also treating the parents and family as a whole. Setting the expectations for what their clinical course may be, as well as their what constitutes adequate pain control. Again, involving the patient's parents to review the postoperative plans, the daily inpatient goals for the patient, the methods of pain management that are going to be utilized, what is going to be the criteria for discharge. Previously, the most common thing keeping patients in the hospital was adequate pain control. And then again, the recovery and goals after they are discharged. So moving into our up-to-date pain control, what does it involve? It involves some aspect of multimodal pain control. What is that for our pectus patients? Well, of course, some of our non-opioids are acetaminophen and NSAIDs, either IV and PO forms. Also, additionally, the use of nerve agents such as gabapentin or pregabalin, muscle relaxants such as methocarbamol, anxiolytics such as benzodiazepines. To some degree, they still will require opioids, particularly in the first few days after surgery. Although we've gotten much better at multimodal pain control and opioid reduction, it's still a painful operation and recovery period. And then analgesic adjuncts and interventions, which we'll get into in the next few slides. Now, patients aren't receiving all of these. They are receiving some combination of these, and there's a wide variation depending on what center you go to or what surgeon whose care you're under. As far as the adjuncts, we'll talk about preoperative medications, regional anesthesia, continuous infusion catheters, and then cryoanalgesia. So for preoperative medications, this is generally done with 2 classes, that being the nerve agents, gabapentin, pregabalin, and the anxiolytics, the benzodiazepines. And the timing of these being as close to the day of surgery or within 1 to 2 weeks before surgery. There's some data, particularly with the nerve agents such as gabapentin, that if patients are pre-medicated with this for a short period before surgery, it's associated with better pain control and lower postoperative opioid use postoperatively. How about regional anesthesia? Specifically, we're talking about peripheral regional anesthesia, not central anesthesia, which would be things like epidural, also colloquially known as nerve blocks. Most common form employed for pectus patients are intercostal nerve blocks. However, also described are paravertebral, parasternal, erector spinae, serratus anterior, and pectoral plane blocks. Next, we have the continuous infusion catheters. Similar to regional nerve blocks and involves placement of a catheter, most often subcutaneously along the surgical incisions, where a local anesthetic can be continuously administered. This can also be placed within the prior described fascial nerve planes, and the use has been described for pectus patients, at least with erector spinae, but theoretically any of those previously named planes could be utilized for this as well. And finally, we move on to cryoanalgesia. This is the most unique form of pain control for pectus patients. Well, what is it exactly? In its simplest form is the use of cold to relieve pain. This is not a new idea for pectus or surgical care. Even in the writings of Hippocrates, he used snow and ice to treat pain of surgical patients. The first modern cryoprobe, which we'll talk about later, was developed in the early 60s, and the term of cryoanalgesia was coined in the late 60s. So how about for thoracic cases? The earliest publications I could find as far as in use of thoracotomies was in the early 70s. And fast forwarding to 2014, that's when the current commercially available cryoprobe was FDA approved for pediatric pectus repair. First case report in 2016, and then a small RCT in 2019, which showed improved pain control and lower lengths of stay. There's been a number of observational studies that have followed up on this, that have confirmed that those results and expanded on that data. So how does cryoanalgesia work? It works by temporarily ablating the intercostal nerves by rapidly cooling them to -65 degrees, destroying the axons distal to the site of cooling. The outer nerve structures are left intact, which allows for nerve regeneration, and an analgesic effect which lasts for weeks to months. And here's a view of the current commercially available probe. As you can see, it looks just like any other thoracoscopic or laparoscopic instrument. Here's an intraoperative picture. You can see here we're in the third intercostal space. The probe is placed along the area of the nerve, approximately 4 centimeters away from the spine. There's a metallic tip that when the device has will rapidly cool to -65 degrees Celsius for 2 minutes, creating that ablation. And we have a video here. We'll see if this will play. So this is a one-time speed video. Again, from that same picture clip, you can see that the ablation is undergoing and cooling. Once the ablation is completed, the device will actually warm back up so it can detach off the wall there, and then you move on to the next space. Most surgeons typically perform cryoablation in 5 spaces bilaterally. So what are the results shown with cryoanalgesia? Overall, lower number of opioids compared to traditional pain control, on the order of 1/4 to 1/2 of what was previously published. Decreased inpatient lengths of stay, down from the average of 5 that we'd seen previously to 1 to 2 days. There's even some recent publications of reporting same-day discharge, same day as a surgery. However, that may be a bit aggressive. And some additional initial data showing lower hospital costs, the lower number of hospital days displacing the cost of using such devices. And although there's limited data, subjectively, patients report that they're typically able to return to their normal activities much sooner. This has allowed some surgeons to expand the offering period outside of the typical school holidays. So we've talked about some of the advantages. What are some of the potential disadvantages of cryoanalgesia? First is the time for onset of action. It takes about 24 hours for cryoanalgesia to have its full effect. This is why surgeons typically pair it with some additional adjuncts, whether that is an intercostal nerve block or utilizing even opioids on that first day particularly. Second, there's a lack of long-term data in pediatric pectus patients, that being 5 to 10 year data. There's some data going 1 to 2 years out regarding persistent numbness or neuralgias, which reports that it's rather rare, but there's still this lack of this 5 to 10 year data that we're still looking for. And finally, there's some concern recently that these patients have so good of pain control that they're returning to some of their activities and ignoring some of the restrictions the surgeons has given them. And some have reported increased complications in the terms of bar displacements. because these patients just feel so well, they're able to return to some of their larger activities, whereas before they're not only restricted based on the instructions, but on their self-limited pain control. And to hit on the last few topics, just for covering all the aspects of updated pain control, the use of ERAS or enhanced recovery after surgery protocols. Similar to what you've seen for other procedures such as colorectal surgery, but the use of standardized perioperative care for patients, the use of multimodal pain control with a focus on decreasing opioids as feasible, the avoidance, early removal of lines and drains, epidurals if they're used, or chest tubes if needed, with again the overall goal of decreasing opioids, length of stay, and overall improvement of care. And finally, discharge medications. Again, although these patients had traditionally received a lot of opioids inpatient, they'd also go home on a fair amount of opioids. So continuing that multimodal non-opioid therapy once the patients are discharged. And then again, just a reminder, it's even despite our improvement in pain control, it's still a painful operation. They will still need opioids to a degree. However, there's some data to say that patients are going home and not requiring them. So potentially in the near future, decreasing or eliminating that altogether. Just a quick summary. Again, overall painful operation and recovery period, use of multimodal pain control and limiting opioids as feasible, and the consideration of adjuncts such as cryoanalgesia and some of the others we spoke of. And finally, to incorporate these ERAS protocols to protocolize and improve patient care. With that, I'd be happy to take any questions. I don't know if there's any on the chat, I can't see.
Great, thank you. I appreciate the talk, fantastic. Right now, I see only one question for John. I don't know if he's still on the panel, but the question is, when is the ideal time to start bracing for carinatum? Are there circumstances when to start sooner? And if, I mean, John, not a bit, Jamia, can you chime in maybe? Otherwise I can't answer.
Yeah, so usually I try to measure the compliance using a little meter, and I still like to do this around the 12-year range. I don't do it too much sooner than that. What's your practice?
I do measure the pressure, and I mean, it does. I mean, this all depends on the compliance of the patient also. Does the patient's going to wear it?
Sure.
Because this is different than teeth braces where they plug it on and you can't take it off when it works. You can take the brace off. So the patient has to be motivated and has to be willing to wear it. And that's usually with the small kids not the case again. So they have to have a certain age to comply. They want to really have to correct it. And then it works, you know, it works well. But so it's usually a little bit older from my perspective, 12 to 14, 13 to 14, something like this. That's when they become, they really want to have it fixed. That determines its success.
Yeah, exactly. Yeah, I tell the parents and the patients themselves, it's not enough to just buy the dumbbells. You actually have to lift them.
Yeah,
so.
There have been early on in Pittsburgh, you know, also before I was involved in this, failures with this because they essentially got the address of a orthotic shop to go there and get a brace, and nobody ever saw them again. And so that doesn't work. You know, you have to really do some follow up. The orthotic shop has to follow up, readjustment, and they have to be a little bit older. Otherwise, it doesn't work usually.
So, so we don't see any other questions, but I'm going to ask the question on your findings of your multi-center study that you did with the cryoanalgesia. In that study, could you remind me if it was an observational study, or did you have was everybody following the same protocol?
Yeah, I didn't bring that study up. It'll actually, full results will be presented in APSA in July. But just briefly, what's that?
It's still secret.
It's still secret, but just briefly, it was just a retrospective study looking at 20 centers experience. There's the idea of using a randomized trial to study some of these items would be difficult. A lot of pediatric surgeons have their own bias on what they believe will work, will not work. So I think certain aspects of it would be difficult to do on that on a prospective basis, but hopefully once that data is presented and published, it'll be one of the larger observational studies regarding pain control for Pectus patients.
Okay, cool. Yeah, we've been doing the crying analgesia in our center for a couple of years now, and we've seen significant improvement in the length of stay. And so it's been quite frankly, for me, it's been a total game changer in the care of these patients. Wouldn't you agree, Stefan?
Yeah, when I did fellowship at Hopkins, everybody got OxyContin, and everybody left and posted their 2. There was not one single patient who did not leave and posted their 2 on BID dose of OxyContin. And and so in Pittsburgh, people stay at 5 to 6 days on average or longer. And I usually send them home with a cryo after 2 days. 1 day is pushing it, 2 days. But of my partners, there's only one other using it. It's new things don't get adopted easily in my place. And I use it also for thoracotomies. If I do have an open thoracotomy, I use it for pain control. I haven't used it in babies, but in older patients or infants, or children, I do use it. And it
worked really well. Yeah.
Are either of you pairing it with other adjuncts, particularly for coverage in that first day or 24 hours? Are you seeing that?
Yeah.
If you're.
Yeah, I do an intercostal block with a combination of Marcaine and Exparel, and the Exparel being the long-acting bupivacaine. And I do a 1-to-1 ratio, and then put 2 cc's in every intercostal space. And that usually bridges over. And then in addition to that, we're also giving the gabapentin, as you had mentioned, and have a patient control analgesia pump for breakthrough as they need it. But with all of that multimodal approach, we have seen a handful of patients that actually came out of the operating room and were ready to go same day after the post-op check at the end of the day, which, as you said, seemed a little aggressive, and so we didn't let them go. But most of them are ready to go by end of the first post-operative day, if not early on the second.
Yeah,
that's just anecdotal. We're looking at our own experience, and we too shall be presenting that sometime somewhere.
I mean, I use it also nerve block because you have time anyway, 2 minutes per level freezing, so you have a lot of time. So I usually use just 0.5% ropivacaine. Exparel, UPMC does not buy Exparel, it's too expensive. We can't get a hold of it. But that works pretty well overall. But really the best I like in this procedure, freezing it to scream freeze, freeze, and then you have to wait 2 minutes, that's the downside. But John, one more thing, there was a question earlier we kind of answered about bracing. When to start it? Would you consider doing it earlier sometimes?
Yeah, I think I've been tempted in some school age kids, 5, 6 years old, to start. And in fact, I've tried that, and in a couple of cases felt like I gave a kid a complex. Again, I think the age of self-awareness really is around 8 or 9 years. And I just feel more comfortable starting then. Generally, kids aren't really bothered to even notice it before that time. So then it becomes a question of who in the room is actually motivated to see this change. So, I think for the most severe kids, maybe 9, 10 on the early edge, there's really no rush, like you said earlier, in regards to the NUS procedure. Don't rush it. You're as much as you're treating their chest wall, you're treating their brain, and keep that in mind. So, but that's a great question.
I mean, I felt with the bracing, the compliance goes really down if you do it too early. I mean, the patient really has to want it, and then it's successful.
Yeah, and again, the durable results comes from holding the sternum in position while you're getting those years of calcification. So you can do a lot of catching up, you know, 12, 13, 14 years of age, and have a patient who's self-motivated and really engaged in their own care.
Right. So I think, you know, we don't have any other questions anymore. It's 6 minutes before 9. Anybody has any other comments from our panel?
Yeah, I just wanted to thank you guys. Thank you all for this opportunity. And I learned a lot. I hope others learned too.
I thought it was fantastic, and thanks for including me. And you know, I look forward to, you know, I'd be happy to continue this kind of effort in the future if you guys are interested.
Yeah, likewise. It was certainly very interesting, and I did learn a lot too. Thanks for joining this panel. Thanks, Ashia, too. Fantastic.
Thank you for inviting me. Great talks by everyone.
Great. I hope you have a good night. It's 9 o'clock, bedtime for residents and some attendings.
All right.
Bye.
Bye-bye.
Thank you.